Introduce yourself to the patient and demonstrate hand hygiene. General survey. Look for signs of distress and see if the patient is properly dressed and oriented. Vitals. Check for serious problems that could be deadly. Heart rate. At least 30 seconds, 1 minute if irregular. Respirations. 30 seconds. Blood pressure. Check both arms in the same position, sitting with feet flat on the floor. Performed bilaterally. Noted. Temperature, using the most appropriate method.
Pearl! Remember that the rectal temperature is the most accurate measurement of the core body temperature.
Head, examine the area of complaint. Inspect for size, shape, symmetry, lesions, lice, and signs of trauma. Palpate for lesions, nodes, and edema, particularly on the right side of the face and jaw due to the chief complaint.
Pearl! For this chief complaint, make sure you remember to palpate the readily superficial temporal artery right in front of the ear.
Eyes. Rule out any eye dysfunction that could be affecting the pain. Fundoscopic. Perform a fundoscopic exam so you can see the optic nerve, disc, and retina. Ask the patient to remove their glasses. Dim the lights. And perform bilaterally. Then assess the patient's visual acuity.
Pearl, remember to have the patient wear their corrective lenses for this component.
Visual fields, superior and inferior temporal and superior and inferior nasal quadrants. Extraocular movements, 6 cardinal directions of gaze. Lid lag, and convergence. And light reflection in the corneas. Also check the pupillary reaction to light. Moving on to the mouth. Rule out tooth pain as the cause of the chief complaint. Begin to inspect the mouth. Okay, using a gloved hand and the proper lighting. Particularly looking at the teeth for number, presence of dentures, caries, fillings, caps, plates, shapes, and any looseness present.
Pearl, the use of a tongue depressor will help you to visualize hard to discover areas.
Thank you.
Skin exam. Examine for herpes zoster and any other skin diseases such as lesions, areas of skin breakdown, and wounds. Inspect particularly on the face for zoster vesicles in a dermatomal pattern. Palpate, checking for any differences in texture, warmth, and tenderness with the back of the hand. Heart. Rule out cardiac emboli caused by TIA and check for murmurs or comorbid conditions causing patient's condition. Auscultate listening for 2 to 3 seconds in each area on the patient's bare chest. Using the diaphragm of the stethoscope in the right second intercostal space for the aortic, left second intercostal space for the pulmonary, left third intercostal space for Erb's point, left fourth intercostal space for tricuspid, the left fifth intercostal space, and the apex. Using the Bella stethoscope, you inspect the left fourth intercostal space, left fifth intercostal space, and the apex. With the patient in the left lateral decubitus position, with the bell, listening for mitral stenosis. And sitting up and leaning forward. Exhale completely and using the diaphragm, listening for aortic regurgitation.
Now the lung exam. Examine to rule out underlying pulmonary disease that could make condition worse or treatment less effective. First, inspecting. Noting the rate, rhythm, depth, and effort of breathing laterally, posteriorly, and anteriorly. Palpate, noting any tenderness, crepitus, or masses in symmetric location. Auscultation.
Pearl, ask the patient to cough first before you begin the auscultation and then to breathe through an open mouth.
Listen for full inspiration and expiration, comparing symmetric areas in a ladder-like pattern. Anteriorly in the supraclavicular space and 3 additional areas. Laterally in at least 2 areas while the patient's hands are on their hips. And posteriorly in at least 5 areas as the patient has his arms crossed in front.
Pearl, fully expose the anterior, posterior, and lateral sides of the thorax before you begin inspection.
Now moving to the neuro exam. To rule out or in the majority of our differential diagnoses and check sensory and motor functioning. Starting with orientation. Asking the patient, who are you? Where are you? And what day of the week is it? Then moving to the sensory component. With a wisp of cotton, light touch on bilateral sides of the face and extremities. Remember to compare proximal to distal to evaluate for the stocking and glove distribution of diabetic neuropathy.
Pearl, ensure to vary the pace so that way your patient can't anticipate your movements.
Next, moving on to the motor component. General inspection, palpation, passive range of motion bilaterally, as well as muscle strength against resistance.
Excuse me. Testing grip strength to rule out multiple sclerosis.
Next, the cerebellar exam. Point to point,
Random alternating movements,
romper,
and pronator drift.
Pearl, remember that MS is disseminated in space and time, so deficits may not always be logical.
Cranial nerves.
Yeah, we're going to start with the first cranial nerve and checking for nasal patency. We've tested already for cranial nerves 2, 3, 4, and 6 during the eye exam. Cranial nerve 5, clenched masseter palpated, as well as the temporalis muscle. Pain sensation in bilateral branches with a use of a broken Q-tip. And with a wisp of cotton, the corneal reflex. Cranial nerve 7 being tested, raising the eyebrows, smiling, showing teeth, frowning, puffing out cheeks, closing the eyes tightly. And cranial nerve 8, the whisper or spoken voice for gross acuity. Moving to cranial nerves 9 and 10, listening to the patient's voice, asking the patient to swallow, observing the soft palate for elevation upon phonation, and the gag reflex. Cranial nerve 11, shrugging the shoulders with resistance, and turning the head against resistance. Cranial nerve 12, inspecting the tongue at rest, sticking out, mobility of the tongue by asking the patient to move it back and forth from side to side, and the strength of the tongue. Lastly, checking reflexes, biceps, triceps, brachioradialis, Achilles, plantar response, and ankle clonus.